Welcome and thank you so much for tuning in to Psychology Is. I'm your host, Nick Fortino, and I have with me today Nesseret Bemient. Welcome, Nesseret.
Thank you so much. Thank you for having me.
It's a pleasure. You have a unique perspective that I'm very excited to kind of hear from, and I think our audience will really appreciate your perspective. It's unique in many ways. You were a psychiatric nurse for 17 years, so you really got to see from the inside, what modern day practices in psychiatry look like. And you also have had your own experience of being a patient of a psychiatrist or multiple psychiatrists, and now you offer services of holistic mental health coaching, and I'll be asking you about the details of that and like exactly how you're helping people. So I just want to say that I really appreciate the way you are speaking out, and sharing your experience. You have, you're active on the X platform. You have your own YouTube channel, which we'll link here in the description. And I'm really happy to kind of introduce you to the Psychology Is audience. So let's, and I'll just say one more note here as we get started. When my friend Robert and I started Psychology Is, we didn't expect to go this deeply into this critical examination of the modern day practices in psychiatry. It's always been a focus of mine. Like, I wrote my dissertation generally on this topic, and for the past 10 plus years, I've been thinking about it very deeply. But again, I didn't really expect to use this channel you know, as a medium to talk about this, but it's become increasingly important to talk about. And I underestimated the appetite out there for this kind of conversation and just how many people can relate to kind of the story that you're about to share of your personal experience of being harmed by modern day practices in psychiatry. So this is very meaningful, this cause. So let's begin by listening to you talk about how you got into the field of nursing and specifically becoming a psychiatric nurse. I would love to hear that story, and then we'll talk about what you witnessed as a psychiatric nurse. But how did you get into the field in the first place?
Mm. Well, I wanted to say first that I really think that this space that you've created to talk about these topics is really huge. And just raising the awareness and connecting with people who are also critically thinking about psychiatry in this field. So I think that's a huge service to people, just even
Mm,
to have this safe space for them to be understood and validated and not, the usual gaslighting
no,
and dismiss, their lived inner experiences. So I think that's really important. So thank you for what you do and also for giving me this opportunity to share my story with your audience as well. So I appreciate that.
no.
Yeah. So um, I'm going to start I'm originally from East Africa, Ethiopia. So I'm an indigenous person. And I grew up in a country where people talked about, evil eyes and possession by a devil when in the context of mental illness, it just wasn't understood. So I had no idea of what modern psychiatry was like. So I immigrated to Canada when I was 13 years old. It was in 1993. And that was because of a civil war that was ongoing in East Africa for a long time. My family and I ended up in a refugee camp in Kenya for 2 years and then found sponsors to come to Canada. And we were the very lucky ones. And so um, it was a privilege for us to immigrate to every country and to have opportunities for education, for learning. My grandmother um, didn't know how to read or write in her entire life. And so um, it's just incredible that we had this opportunity to do these things, to learn and to have education and employment and all that. I never really grew up thinking about wanting to be a psych nurse. I didn't even know what that meant or how it was. It just kind of, I was led in that direction when I was going through university doing the nursing program. My last year of last semester was mental health, and I really just fell in love with just trying to understand human psychology, because that was something I was grappling with in my own life, trying to make sense of everything, my experiences at such a young, like tender age, going through really challenging experiences and trying to just really figure out who I was. I went into nursing right out of high school. And I thought I was going into the state of the art, modern psychiatry, psychology. People know what they're doing. There's evidence-based practice and scientific research and all that stuff. So I had kind of like this idealized version of what the field was going to be, and thought, nursing is an honorable profession, and that's where I was going. And the reality of my experience was very different from what I had imagined it was going to be.
Yeah, for those of you who are also watching along with listening, you can read into your smile here just how extreme the discrepancy was between
Yeah.
what you expected and what you saw.
Mm.
Um, well, yeah, just kind of a fascinating journey up until this point already. And so so at this point you decide, after that inspiring semester learning about mental health, you decide to pursue a psych nursing specialization.
Mhm.
And then
Yeah.
what?
So, yeah, go ahead.
I was just gonna say, I was gonna say, you go ahead. And then what happens? What happens next in your story?
Yeah. So, right after graduation, I went into acute care. That was my first job. And I was there for 4 years. And this was a locked unit, psychiatric unit, where we saw the range of people who came either from the community or emergency that have, diagnosis of anxiety, depression, bipolar disorder, schizophrenia, OCD, eating disorder. It's just was a catch-all unit. And it was incredibly jarring to be in that environment. Um, I remember being given a tour of the unit, and just when I first started, and I saw these people just kind of wandering the hallways with kind of glazed look on their faces, nurses, carrying cocktails of drugs and rushing. And then there was somebody banging on the door, on a locked door. And I was told this person was agitated, was put in a seclusion room. It was just a very chaotic environment. And I just remember thinking, this is really odd. And one of my roles as a psych nurse was to administer the drugs and that were prescribed by psychiatrists and monitor the effect of those drugs. And I was amazed right away how much drugs were used. It was really the main mode of treatment and the first line of treatment, and the rush for diagnoses. So, like, you would see an emergency physician or a psychiatrist you know, either in the community or in emergency or in acute care. And after 45 minutes, an hour of meeting this person, the person will have a diagnosis. And that diagnosis is going to follow them for the rest of their lives. And that's not based on a brain scan. It's not based on a genetic testing. It's not based on a blood work. It is from a book called the DSM of a list of criterias that is really subjective for the most part, either by the patient or the psychiatrist or whoever is making the diagnoses.
Hmm.
And it's not to say that a diagnosis cannot be helpful. I think for clinicians, it can give them a framework to understand someone, but to confuse that diagnosis with a person's identity and who they are in their entirety is a huge disservice. And for many people, I noticed that a diagnosis initially might come as a relief, but then it becomes the chain that binds them and disempowers them.
Mm.
And for clinicians, once you label that person and you're looking at them from that lens, then everything is looked at in that context. You're not really getting to know this person, who they are. That's just one aspect of what's going on with them, life challenge or circumstances. So what I noticed with the drugs right away was patients would tell me it's not working, it's making them more agitated. For a portion of them, a portion of people just could not tolerate psychiatric drugs, period. And the ones that could, are considered psychiatrically stable on high doses of drugs, often multiple drugs, they always complained that they are having to live with serious effects of the medication, side effects. And I don't believe there's such a thing as side effects. There is whatever you're experiencing on that drug is the full effect of the drug. And so, they would have, especially the people who were on neuroleptic medications, but all of the psychiatric drugs, weight gain was a huge one, sexual dysfunction, fatigue, lack of motivation, lack of energy, brain fog. So this was like an all-pervasive sense of just being subdued. And a lot of people would say they can't access their emotions. And so very quickly, I realized that, first of all, the rush to diagnose, even though we take the person's history and to some extent in the context of what they've been through, what you're witnessing is understandable. Many of the people, I would say almost 100% of the people that I've worked with had significant trauma history. And that's not to say that's the only factor. In fact, the issue is that there are multiple factors that impact a person's health, starting from utero to the grave, in terms of diet, the mother's stress while she was pregnant, nutrition, genetics. There's just a plethora of things that influence a person's mental health. And so those things are not really seriously taken into consideration, and the interventions given accordingly and truly explored before you come into a very high-risk intervention, which is psychiatric drugs that have just the potential to wreck a person's life.
Well said. Yes, there's a few things I want to highlight just from what you just said. It's so validating for someone to hear the statement, given everything you've experienced, what you're going through right now makes perfect sense. It's totally understandable. It's not indicative that your brain is malfunctioning. And that there's this plethora of factors that can contribute to someone's emotional state or, distorted perceptions are not taken into consideration when developing an intervention. This is such an important point. We're missing the cause. We're not addressing the cause. And I think people are made to believe that by taking a drug that's been prescribed to them, they are addressing the cause, because they're made to believe that the cause is this chemical imbalance or some type of neurological abnormality that the drug supposedly is correcting, which we know, of course, that is not the case, but that's how people are led to believe. I also want to emphasize what you were talking about regarding diagnosis and maybe kind of add a little bit to that.
Mhm.
I think this is a really interesting question. Like, what is the impact of a diagnosis? And like you said, it can come with relief. And then, though, it's kind of the chain that binds you and it follows you your whole life. And it's highly stigmatizing. And I would add to that that it tends to instill into a person a very fixed mindset about their mental state. They believe that if they've been diagnosed with ADHD, well, that's just how their mind works. They're always going to be inattentive and impulsive. But that is not the case. And it's very important, I think, that people understand well that psychiatric diagnoses are descriptive, not explanatory. And I think, honestly, that part of the relief comes from misunderstanding these diagnoses as being explanatory. And just to kind of, elucidate what we mean here, that is to say that if you are having coughing fits every day and you go see a physician and then you're diagnosed with bronchitis, that's explanatory, right? We're saying the reason you're coughing is because you've been affected by this virus and we call it bronchitis. That explains your coughing. That's how
Mhm.
most medical diagnoses are made. But mental disorders are not diagnosed like that. They are diagnosed purely based on you presenting symptoms. And
Mhm.
so, in other words, ADHD, for example, does not explain why you're inattentive and impulsive. It simply affirms that you are inattentive and impulsive. And the equivalent here with the coughing and bronchitis example would be like if you were coughing and you went to see a physician and they said, because you're coughing 35 times a day, I diagnose you as having coughing disorder. That's what mental disorders are like.
Mhm.
So I don't want to kind of take away from any relief that someone may be experiencing having been
Mhm.
diagnosed. I think the relief can be positive, but I also think it is based in misunderstanding the diagnosis as though it's explaining something. And I think the most problematic consequence of that is that when people are diagnosed and think it explains their condition, they then stop searching for the cause of their depression or their anxiety or their inattentiveness. But there is a cause, which may be biological in nature, metabolic issues, hormonal issues, could be neurological abnormalities. Maybe a brain scan is called for, or it might be psychological in nature, like unresolved trauma, or it may be environmental in nature, like an abusive, stressful, impoverished community or household. And
Mhm.
so it's just such a terrible consequence that a person would stop looking for why they're depressed or anxious once they get a diagnosis. And again, that's because of this misunderstanding that these diagnoses are explanatory. And I understand why people misunderstand them in that way, given that every other medical diagnosis does tend to be explanatory.
Mhm.
So anyway, I just
Mhm.
wanted to kind of emphasize that point and add those thoughts onto it. Um, so you're kind of, we're adding commentary here as you take us through your story. And so far, you've shared that you worked for 4 years in the psychiatric unit. What
Mhm.
would you call it again? The acute psych unit,
Acute care. Yep.
acute care.
Acute
Thank
care
you.
unit. Mhm.
So you spent 4 years. You were the one administering medications. You pointed out a little bit now, and we also had a preliminary conversation where you told me this that essentially you were the one monitoring the effects of the drugs,
Mhm.
not the prescribing physician. And that's always so alarming to me. And I witness it, especially with the work I do in the jail. I witness this that the psychiatrists who are prescribing these drugs are not watching closely what the effects of the drugs are. So, and you described what many of the effects are and how
Mhm.
ultimately I love that you said what is true, which is side effects is a bit of a euphemism. There's no real
Mhm.
such thing as a side effect. There are just
Absolutely.
adverse effects, undesirable effects, damaging effects, but they're
Mhm.
not like off to the side of anything. They are the effect of the drug.
Yeah.
Um, so anyway, I just wanted to share those thoughts, but please continue, talking about your story and your interpretation of everything that you witnessed.
Yeah, absolutely. And I love that you brought up the point of just, the language in psychiatry in terms of the diagnosis, the DSM, the message that we give people. Some of it is a lie in terms of the chemical imbalance theory and all of that, because language can be so powerful.
Right.
And the language in psychiatry is almost like a prison for people.
Mhm.
And it's not empowering in the long term for a person to have this lifelong diagnosis and you are sick and you have a disorder, a brain disorder. It's just incredibly, it's a sinking feeling. I have seen these diagnoses being handed out in a meeting for someone who's 18, 19-year old, being told this. It's incredibly devastating. And initially, like you said, for some people, it might come as a relief, but then it just becomes this heavy burden
Mhm.
that they have to continue to live with this and then manage this and they have to take these drugs. And it's just none of it, looking back now, I realize is really necessary or true. And you listed these different factors that could be affecting a person, and it could be one or two things, and it can be the combination of all of the things that you just mentioned.
Yeah.
And so, this idea of getting to know someone in a 45-minute conversation is just ridiculous because a human being, you can spend your entire life trying to get to know someone. And if that could be your mom or your brother or your best friend or a colleague or whoever it is, and you would never parse out all the layers about that person, truly understand. The same as ourselves, because we're changing beings and we're complex and we have many layers, and it's not this simple. To reduce a human being to a 45-minute conversation and a diagnosis and just tell them that is who they are is just ridiculous. Um, so to go back to my story, I remember thinking, I first of all, after the 4 years, I went into burnout myself because being around that environment day in and day out and witnessing people at the height of their crisis and I think really that is the explanation. I was always amazed when I was doing intake assessments with people and or when they come in and we go into a meeting with the team and hear their stories. I was just always floored to think like, how did you survive the things that you went through? Like how are you here in front of us talking to us? And those are the type of people that I, over the years, when I look at the patients and clients I've worked with, I've been privileged to serve. They were courageous. They endured so many terrible things most of the time. They, you know, were in crisis, whether that's their identity crisis as a young person or a spiritual crisis or relationship. And they were very sensitive and caring. Um, and so it was just a group of people that are suffering what we call quote unquote mental illness. And I prefer to think that it is just life's challenges and problems. It's not to deny. And I know people can be really sensitive around this. But the truth of it is, I understood when I sat in front of them that it's understandable the state of consciousness that they're in and the challenges that they're facing and the symptoms that they're exhibiting as in the context of what they've been through. And this is not to say that, like I said, it's not a simple thing. It's not something that we can just attribute to one thing, even if it is a genetic or trauma or stress or whatever it is. But it's a combination of everything that we go through. And so I remember thinking when I was in acute care that I wanted to go where in the community, worked in the community where there are people who are psychiatrically stable and healthier and moving forward in their lives. Like, I don't want to see people at the height of their crisis and being drugged and medicated heavily and go through that process. But I also, like I said, over time, you go through as a clinician, I'm sure you know, having to witness people's trauma all the time. There's such a thing called vicarious trauma, which is just people who are first responders, mental health professionals, police officers, having to witness other people's pain and suffering all the time will impact you. And so that's where I was. And I had this, again, this naive idea that in the community, the people that were considered psychiatrically stable were going to, it was a more hopeful place to work. And that was the time that I myself entered in this system personally, in terms of like just being diagnosed within the community. I was still working. I was not hospitalized. I just went to see a family physician and they diagnosed me with depression, and there was more to it. But my work in the community, I've worked in as a mental health and addictions case manager, outpatient case manager for 5 years after that. I worked in a methadone clinic. I've worked with the homeless population. I also did child and adolescent psychiatry for 7 years. 5 of those years was an emergency, and then 2 years in adolescent treatment center for kids with concurrent disorder, which would be a mental health diagnoses, trauma, and addictions issues. So I had a really range of experiences over the 17 years. Psych nursing is the only discipline that I've practiced. And I realized when I was working in the community, people would cycle in and out of hospital. The ones that were considered psychiatrically stable, they were still struggling with the effects of the drugs, negative effects, harmful effects. And there was a lot of harm that was just being dismissed, and people are being told, you don't have any other options. Would you rather be crazy and, have mental illness that's untreated, or would you rather be on this drug and still maintain some sort of resemblance of normalcy, but still have to live with all of these drugs, the effects of the drugs? And so that's not a good option, but also the other interventions that I know now could be really impactful, such as metabolic therapy, so the ketogenic diet, exploring spirituality, whatever that means to the person, meaningful work, meaningful connections, mindfulness. I always say there's 1,000 paths to healing. And
Yes.
medication might be part of that process for some people. Personally, I've come to the conclusion that psych drugs can be useful in acute crisis for a period of time and for short-term stabilization, but long-term, they're not helpful to most people. And the other piece is I've learned more recently that a person can have a terrible adverse reaction that will cause them serious harm that's ongoing and permanent, even with just one dose of the medication or the lowest dose of the medication, or even being on the medication for a couple of weeks or a few months, and then they are having to live with iatrogenic harm on an ongoing basis. So it's something that should be used judiciously, especially with children and with developing brains. But that's not how things are practiced in the system. And if you look at the antidepressant and psychiatric drug sales in the US, around the world, it's tremendous, tremendous.
Right. Which kind of can be sometimes the elephant in the room, the extremely profitable nature of these drugs. This is something I know we had a guest on the show named Anna Lemke, who's a professor at Stanford University, and she wrote a couple books, one of which is called Drug Dealer, MD. And she really highlights this. And I think it's powerful to hear someone who is, maybe mainstream, at a mainstream institution say such a thing, that her role as a psychiatrist had gotten reduced to essentially being a glorified, societally sanctioned drug dealer.
Mhm.
And this is not inflammatory to say. I mean, this is just really happening. And there's a range, of course, I'm sure you can really speak to this, that not all psychiatrists are the same. Many are much more careful. There's a spectrum here. But on the worst end of the spectrum, it is completely unacceptable. It's just a disgrace to see what happens, in on that worst end of the spectrum. The
Mhm.
psychiatrists who just nonchalantly diagnose people and prescribe them drugs, even if they're toddlers or young children. And if the drug isn't working, they'll just increase the dose or add another drug on top and just collect their money and just live their lavish life while they lie to people, mislead people, cause people to have horrible adverse effects to these drugs and become dependent on these psychoactive substances. It's just there's like a rage that wells up in me, especially when I think about the psychiatric drugging of children. And I just want to again highlight a couple things that you said. I think it's also needs to be talked about more, this thing that's happening where family physicians are making these diagnoses and prescribing the drugs, as in the case of what happened with you. This is
Mhm.
very common, and I'm trying to kind of track down the exact numbers, but I know that, like, I recently saw something that, the former DSM chair, Alan Francis wrote, and I think he quoted that the majority of antidepressants now are being prescribed by family physicians, not even psychiatrists.
Good.
And in my bold opinion, I don't even really think psychiatrists are trained well enough to analyze someone's mental state. And I know that's
Mhm.
bold to say, and that might make some people mad, but that's my assessment. And yet, at least they get some level of training, but a family physician, zero training in that. I can't believe that they are
Yeah.
able to prescribe psychiatric drugs. It just seems so outside the scope of their practice. So it's just
Mhm.
it's appalling, especially when you look at these kind of the worst aspects of this um, very problematic picture. It's appalling.
Yeah. Absolutely. It's not their area of expertise, and they don't have the time. Most places there's shortage of physicians, so you cannot assess someone's mental health state in a one-page questionnaire like the PHQ-9 or the GAD-7
No.
and decide that you're going to start them on a drug and then see them 6 weeks later, where they could have developed serious adverse reactions in between. And people are not often told fully what they're getting into when they're put on these drugs in terms of informed consent and how difficult and harrowing it's going to be to come off of some of them. For some people, they can start a medication and they can come off of it okay. Other people will have a terrible time. And so, but I totally agree with you. I don't think physicians should prescribe psychiatric drugs at all. And for the psychiatrist, they should prescribe incredibly judiciously. And that's not the practice
No.
with kids or adults,
Mm.
both.
Can you tell us more about the trend of polypharmacy? What exactly that means? How common is it? And why is it problematic?
Mm. Yeah, I have seen that in children. I remember when I was when I was starting in the children and adolescents unit, one of my preceptors telling me they had a child that came in, a 10-year-old, and had been prescribed 10 different psychiatric drugs, and his heart stopped and it had to be rushed into an ICU. Yeah. So whoever that person is that would prescribe 10 different drugs for a child, that that is complete negligence. And over the years, I've seen kids on 2, 3, 4 different drugs, the same for adults.
Mm.
You start out with one thing and then they'll add something else as an adjunct treatment, or the person will develop metabolic syndrome. So now they're going to be pre-diabetic and or their blood pressure is high. And so they'll add a couple of medications for that. Also, it's not uncommon for patients to have multiple diagnoses, either from the same psychiatrist or different psychiatrists. Oh, I have anxiety. I've seen people who are treated with antidepressants. Now that has triggered on higher doses an OCD type illness or a bipolar type illness. And it's a complete mess. And so that is a common thing in psychiatry. And that's the only conversation you have with your psychiatrist. When you go to an acute care unit or when you go to see your psychiatrist, the one old boring conversation that you're going to have with them is this drug working? Do we need to increase the dose? Do we need to add another drug? Do we need to take you off this one? They'll ask about how are you sleeping, what you're eating, but that's not the focus. It's lip service. It's not an intervention.
Mm-hmm.
And so it's a serious problem.
If I may jump in and share an anecdote to further illustrate this, just about 2 weeks ago, I'm meeting with a group of men that I meet with twice a week in the jail. And, one of them has shared with me that he's been prescribed antidepressants. And of course, I'm curious, I'm tracking all of this very closely. So I want to know like the details, like what did that initial session look like and et cetera. And what he shared with me that day was, he was like, yeah, I just had a meeting with my psychiatrist and this was how the meeting went. So first of all, in the jail where I work, ever since COVID, the psychiatrists are now just doing Zoom meetings. So they're not even meeting with the individual in person. And then when, after the initial meeting and the diagnosis and the prescription have been made, this is what people tell me, that they typically meet with the psychiatrist once a month via Zoom for about 5 minutes. And this man was describing to me his recent meeting with the psychiatrist. And what he said was, he was like, yeah, the guy was driving and he just had his phone like on the passenger seat. So this, the inmate, the man I was talking to, just like all he saw was like the ceiling of the car. And the psychiatrist, of course, was not like looking at him at all. And he said that the conversation essentially went like this. So how you doing? Are the drugs working? No? All right, we'll up the prescription. We'll up the dose. That was essentially it.
Mm.
It's
Yeah.
a disgrace. It's an absolute disgrace that anyone would call that a medical practice.
Yeah. Where's the bedside manner and where's the compassion and empathy and just humanity and all of that?
Yeah. Yes.
Mm-hmm.
So it's interesting to me too that you kind of saw such a wide variety of people and communities. And so is it your observation, I know you sit in the acute care unit. It's kind of the first line of defense. It's the only conversation you're having. 100% of the people who are admitted to acute care are prescribed a drug, which is also very questionable that really needs to be the treatment for everybody. And then, you've worked with children and adolescents in the homeless community. And so you see that this is all pervasive. Is that your observation, that this kind of, loose prescription practicing pervades all of these communities?
Oh, absolutely. Absolutely. And it's no different in the community or at a homeless shelter or anywhere else. In psychiatry, this is the first line of treatment and defense. And then also, people are told, of course, to go seek therapy, and therapy has its own risks. And it can be helpful, but there's many other things that could be explored. A lot of the times I remember being in the community and having just such high caseloads, and I was still managing medication, even in the community, giving people, long-acting injections, making sure that they're also continuing to see the psychiatrist, and the medication are working. Most of the time they weren't working, so we have to try something different. And many people in psychiatry, like the elephant in the room, is that there's a huge amount of non-compliance. People would not want to be on those drugs because they are not working for them. And I remember working in the homeless shelter, and a gentleman said to me, well, at least the street drugs, I have some value. I get some enjoyment out of them. Psych drugs, he said, is just bad all
Yeah.
around. There's no benefit to them. Of course, some of the psych drugs are sold on the streets as well. They have a street value.
Yeah.
But that was kind of the way he looked at it. And so that was something I realized over time. And then with children, the same thing, 14-year-olds being on SSRIs, prescribed by a family physician, would present to emergency after being started like 3 or 4 weeks ago. Now the person is cutting or suicidal or intensified suicidal ideation. And so, or kids that come into emergency overdosed on their prescribed medication. There was just a lot of that going on. And especially, I think the young generation too, this has become really normal. They see everyone else, the adults in their lives are on antidepressants, family members, and, they go to a physician and they're offered very quickly these drugs. And so kids even come to a place of thinking that is the solution. And with a kind of a burgeoning identity, especially in youth, like 13 to 19, they're searching for an identity. They're confused. It's a rite of passage. And instead of helping them process that and going through that journey and helping them understand themselves and find their healthier identity, we give them a diagnosis and a drug. And then you see that child going through all of that up and down and a tumultuous time. And now you have they have something else that they have to contend with, which is the effect of the drugs.
And I would add to that I've noticed, especially as a college professor who kind of works with the demographic of people who are kind of right after that stage of development, that if they've been diagnosed during that identity-oriented phase of development, the diagnosis becomes part of their identity. This is a very, very consistent trend. Whatever the diagnosis may be, and it's most often ADHD or GAD or MDD or OCD or ODD,
PTSD. Oh yeah,
yeah,
all
you get
the
it. PTSD,
wonderful alphabet letters.
right. It
Yeah.
becomes part of their
Yeah.
sense of self, their
Yeah.
self-narrative, their sense of identity, and then, honestly, I do find that that's where you see, like defensive reactions to any kind of questioning about the legitimacy of, or the construct validity of a diagnosis. If a person identifies as a person with ADHD, when you then start to question the validity of the construct of ADHD, it almost feels like you're kind of questioning them and the validity of their experience.
Yeah.
It's problematic.
Hugely disempowering.
Yes,
Yeah.
it's empowering. So you were starting to talk about your own experience, and then we've kind of gone in a different direction, but I'd love to come back to that. After you were diagnosed, what were you diagnosed with, if I may ask?
So at the time, I was 30 years old, and I had just, like I said, went into burnout from working in acute care for 4 years. But at the time, I also had an undiagnosed and untreated low thyroid problem, which usually those symptoms mimic psychiatric symptoms. And I'm pretty sure at that point too, I had some unresolved childhood trauma, which I have a significant trauma history. And so there was like many factors there that came together. And when they did the lab work and they found that the low TSH levels, the physician suggested I should start with the treatment for hypothyroid, but also an antidepressant at the same time, which is really the wrong thing to do, because the better protocol would have been, and the typical, to treat the hypothyroid symptoms and see if the psychiatric symptoms resolve before going into anything else. But
Right.
nothing else was explored at that point. There was no discussion around the nursing burnout. There was no discussion around the childhood trauma, or that even I was an ethnic, like indigenous person that could potentially have sensitivities to psych drugs, which many people do, many different cultures do. And so there was no a holistic assessment or even, grief and loss. Any of that was never touched. It was just, here's the drug, started. And within a couple of weeks, I became hypomanic. And I had never experienced a hypomanic episode prior to that. And even though, I had gone through really challenging things in my life, I would say by any definition, I graduated from high school with honors, a full scholarship. I finished my education. I was in a healthy, loving relationship. I had my daughter when I was 23. Like, life was good. And I would say I was a resilient person. And then from then on, I tried to come off of the drug within a couple of weeks. Um, and I discovered that there was withdrawal from trying to come off of the drug. But also, while I was hypomanic, I quit my job and I didn't have any like kind of contingency plans. I I was the effects of the drugs were I made some decisions that were life changing, and so the wrong diagnoses and the wrong medication can really destroy a person's life, their finances, their relationships, their physical health, their sexuality, their self-esteem, dignity. It's just like it can be incredibly damaging. And but the other piece is when I went back to my physician um, after time, they said, no, you have an antidepressant induced bipolar disorder. So you're going to need more drugs. And I was trialed on 10 different medications and I had adverse reactions to all of them. One of them was a medication called Lamictal, and I had the rare adverse reaction, which was called Stevens-Johnson syndrome. I felt like I was really dying and it could have been fatal and I was on the lowest dose of that drug. So by the time I was on treated with psychiatric drugs for 13 years altogether. And the entire time I gained weight, I had brain fog, I experienced hypersexuality in one of the antidepressants, which destroyed my relationship, my previous relationship. And I had suicidal ideation. I had never experienced suicide was never on my radar. I just never considered it. I don't know if it was because of the culture that I came from, or it's just as a person, I always thought I liked living. I liked learning, growing, and just being alive. And so the first 6 months after I was started on the antidepressant, after my first hypomanic episode that fall, in winter, I went into a suicidal depression and and that continued to intensify with more drugs. And that was probably the most kind of disturbing thing because I had things to live for. And I had my daughter, she was young. And I would say, um, I felt like the drugs were kind of like I describe it to people as a chemical lobotomy. And I know that's a strong language, but that's the truth of it. And many of my clients have said the same thing to me. I don't know who I am anymore. And you go to a very hopeless place over time. And I had to question myself, is this my fate for the rest of my life? And it was incredibly difficult. And I would say one of my cherished values as a person was being a good mother. And I became to some extent emotionally absent. I was struggling. I was barely keeping my head above water. I still continued to work throughout. And that was part of what started to make me question and look at psychiatry more critically because I was in the same boat as my patients in terms of suffering. I wasn't providing them the help that they needed. And And so it was just this place of feeling powerless and also questioning my career at the same time. It was it was a terrible, kind of harrowing experience.
Mm. Wow.
Mhm.
And it's just noteworthy that you overcame, so much adversity throughout your childhood, and still none of that even made the thought of suicide enter your mind. So I think it's very important that people realize that suicidal and sometimes even homicidal thoughts can be brought about by psychiatric drugs. This is something that some people try to deny and explain it away because they could just say, well, it was the disorder itself. But when we hear people like you share your story, we realize those thoughts never occurred to you prior to taking the drug. This is, I mean, it's unbelievable that we call these treatments, mental health treatments. And I
Mhm.
think you did a nice job of kind of balancing everything we're saying by acknowledging that there may be some use for at least some of the psychiatric drugs, and that use is in acute crisis situations for the short term. And
Mhm.
I agree. I totally see that. And that's not how they're used. They're used for chronic situations. People are told that they need to be on this for the rest of their life at ever increasing doses. So there's just such an extreme discrepancy, like you started the conversation with, between evidence and practice. So how did you emerge from, the darkness of the situation that you're describing to us? How did it get better?
Yeah, I started really just researching and trying to figure out a way to feel better. And I came across um, initially, like, I just started to do certain things intuitively. And for me, the biggest things that helped was initially I was on birth control pills, which I think are really huge contributing factor to anxiety, depression,
Or
and mood issues. So I got off of that. And then I gave up shift work and really kind of reset my circadian rhythm, my sleep pattern, regulated more. I sold my car and just started walking everywhere, like 5 to 10K a day. And then I came across and I researched about intermittent fasting. So I was really consistently in ketosis for a while. I was sometimes doing just one meal a day. And then I came across the ketogenic diet community, like metabolic psychiatry. And I'm talking about like Metabolic Mind on the YouTube channel, Dr. Palmer's work with brain energy, Dr. Georgia Eid, Bipolar Cast with Ian Campbell and Bizuki, Shabani Sethi from Stanford. Like there's tons of people, and these are just a few people that I would mention. Um, and I started initially with carnivore, which is an elimination diet. And it's fantastic for just figuring out what really works in terms of what agrees with your body and what you have sensitivities for. And metabolic psychiatry essentially is sort of the intersection between studying the metabolism and mental health and nutrition. And so I started implementing that about a year and a half ago or so. But I think I had really prepared my body with all of the other things that I did previously, reducing stress. I was in a healthy relationship again and very supportive partner. And all of those things I think contributed. So when I came across the ketogenic diet, I was able to implement that, which I think is one of the most powerful interventions. And it's not to say that it works for everyone, but it's definitely worth exploring along with other simple interventions. And so I was able to taper off multiple psych drugs and have been medication-free and symptom-free for about a year now.
Uh,
Yeah. And I
that
think, the
great. Yeah.
biggest thing was, really gaining sort of like my mental clarity, um, my energy. I lost weight, like I'm at my ideal weight, and rebuilding my relationship with my daughter and being in a healthier relationship. I also decided to leave psych nursing altogether and started coaching people around their recovery through metabolic therapies and the ketogenic diet, as well as tapering off psychiatric drugs. And so my life has really completely changed in the last year or so, in the last couple of years.
Uh, and it sounds like you really did model what you preach about, which is the holistic approach. I heard you say you regularized your sleep patterns. I heard you say you increased movement in your life. You addressed the nutrition. You addressed your relationships and perhaps the general levels of meaning in your life, especially by strengthening the relationship with your daughter. That's the well-rounded approach that is probably called for everyone. I recognize that there are rare cases where there may be a singular cause. I know you and I have talked a little bit before about like the work of Daniel Amen, who has the famous TED Talk, What I Learned from 83,000 Brain Scans, where he talks about his own nephew who started developing these aggressive tendencies and was diagnosed and prescribed psych drug. And then he, Uncle Amen, scanned his nephew's brain, found a tumor pressing against the amygdala, and then they removed the tumor and his behavior normalized. So what I'm
Hmm.
saying is I recognize that in some cases there may be a primary or even singular cause, but in most cases it's a multitude of factors, and therefore
Yeah.
the solution needs to be just as multitudinous, like you're describing. And
Hmm.
even if it is like, let's say, um, a severe unresolved trauma, like a pretty primary cause, even when that's the case, a holistic approach is still called for because, for example, a person is so much more able to process the intense emotions of trauma healing when
Hmm.
they're biologically stable, when they have this, the support of good nutrition and movement and all of the kind of brain chemicals that get released through exercise and good nutrition. So what an amazing, testament you are to the effectiveness of a holistic, well-rounded approach.
Hmm. Yeah, thank you. Absolutely. I think the solution is always um, not just one thing. And people deserve to have different options and try different things to see what works for them and find their unique sort of path to healing.
Right.
Um, absolutely.
So I know that, in my experience doing this podcast and hearing from so many audience members, there are many people who are desperately looking for someone to help them taper.
Hmm.
And I heard you say that that's part of, your service that you provide. And I think you
Hmm.
are very well qualified for that with your experience on a personal and professional level. And
Hmm.
I know it's individualized and that it's probably more complex than anything you can express in a minute. But if
Hmm.
you were to summarize, just to give people hope and so that people know that in the same way that anyone can overcome an addiction to a street drug, people can come off of prescribed drugs. How would
Hmm.
you how would you summarize the process by which people can safely taper off of a psychiatric drug?
Yeah, I think the most important thing in this process is to nurture your body and brain with all of these different things so that you'll be going through, because for tapering for some people is going to be very challenging. And it has to be done very slow and very methodically and with supervision and support. And if you can do that, then that process is going to be safe and you're not going to cause yourself more harm. But it is definitely something that can be done. It's hopeful. And that responsibility really is with the prescribers to really regularly check to make sure this person can do that and to provide that support. But that's not available at this time for most people. But the only thing I can tell you is that it's possible. And you just have to have the support and education that you need to go through that process.
Mm. So maybe one of my last questions here is,
Mhm.
I want to really become like solution oriented. I think I've done a good job at hosting guests who explain very clearly what the problem is. And I know that,
Mhm.
looking at all the comments that have come in and emails I've received, people really want to know more. Like they're convinced, they get it. This is a huge problem. Psychiatry is not the best, you know, uh, treatment to seek out. But what's the solution? What's the alternative? Um,
Mhm.
and so that's what I want. I want to offer really good solutions.
Mhm.
And you've offered many really good solutions. So I
Yeah.
appreciate that. Um, and I also want to so I want to be able to offer solutions like for an individual who's going through
Mhm.
something, but I also want to
Mhm.
be solution oriented when it comes to the big picture, the industry level solution. And I would love to hear your thoughts about that and maybe share some of my thoughts about that. But first, what would you say? Like, what do you think the path forward is if we're going to, on a big picture level, solve this problem?
So there's two parts. One is on the individual level, which is the person taking responsibility for their mental health and advocating for themselves and seeking solutions that are outside the box, outside the authority figure. On a bigger scale, if you're looking at it from um, an industry perspective, the education has to change. People need to be taught differently, um, more accurately, and the reckless prescribing has to stop. And we need either to get rid of the diagnostic system or come up with something different because it's not helpful to people. And the World Health Organization said in 2017 that the biomedical model, namely treatment with drugs, is not helpful to people. And we need to approach this from a much wider lens and perspective in understanding people and human beings and in how we treat them as well. And yeah, there are many things, some of the things that work for me might not work for you, but there's going to be things that work for you that are going to be different because you're a unique human being um, that has just a unique genetics and life experiences and reactions to nutrition or drugs or exercise. So everyone is really unique. It can't be a one size fit all approach.
Mm.
And if you can do that, then people have options. They're not kind of just stuck in this one solution at one place. And also, how we treat people and how we view them is what they become. They rise to that occasion. So, handing someone this diagnosis for life, I don't think that's a good practice. I think there needs to be more openness and
Mhm.
possibility in healing for people going into remission or in a couple of programs in Europe, for example, the Open Dialogue program, and then there's another medication-free hospital in Oslo. There are different ways to approach this that can be actually quite helpful and effective. And to think that your way or one way of being or doing thing is the only way, it's actually pretty arrogant.
Yeah.
Um, so to me, it's just we have to look at this from a much wider perspective. And then in terms of, I really believe that one of the futures of psychiatry, a bright future, is around metabolic therapies and the ketogenic diet. There is ongoing research that's being done right now around its effectiveness, but that's also been an effective treatment for refractory epilepsy. And there's already 100 years of research with like 50% remission rate from 1 to 5 years of treatment with the ketogenic diet. So that disorder actually shares a lot of the drugs that are used to treat epilepsy. They're also used for bipolar. So if it can help stabilize brain chemistry in someone who has seizures, why wouldn't it have that like implication in other disorders as well?
No.
And so it's just that openness and curiosity to be open to possibilities for people and not to give them hope and to hold. That is our job as clinicians, is to hold hope for people and to support them when they're going through these types of challenges. And then also not to pathologize human suffering. This
Yeah.
is not anything new. We go through, rites of passage, spiritual crisis, identity crisis, and all the things that are going on in our world today can be very overwhelming for people. Being a modern person is not easy. Yes, we have all the conveniences, information, technology, but that still doesn't change that the experiences that we have as human beings, which are universal usually. And so why would we treat that? What we need to do is hold space for people, to be with them when they're going through dark moments or challenging circumstances, and not wanting to immediately extinguish adversity or challenges or drastic states of consciousness as being a disorder and an illness.
Well,
It's trying to understand them in the context of where they're coming from and what's going on for them and what can we do to support them. And it's, yes, if medication can be helpful in those situations, it can be part of that process, but not the end all be all for everything.
Beautiful. Beautiful.
Mhm.
Yeah, you nailed it. I don't have much to add to that, honestly, because I agree with all of that. And I know that some of my thinking, I've thought to myself, like, is this kind of going to be a bottom up or a top down transformation of the, mental health industry? And I realize it doesn't have to be either or, it can be both. But perhaps most immediately, it will be bottom up. I think there's a better chance of reaching a tipping point regarding educating the public than there will be of reaching a tipping point of psychiatrists who are ready to kind of profoundly rethink the way in which they're practicing their whole paradigm. But we can work from both ends. And, if I
Mhm.
were to say anything to psychiatrists, I would say you must recognize that we live in a culture, like so many countries have this cultural conditioning where there's this message that we hear over and over of trust your doctor. So what I would say to a psychiatrist is be trustworthy because you have not been trustworthy. That trust in you has been misplaced. And so it is your responsibility, I say to psychiatrists, to be trustworthy, to practice in an evidence-based way, and to continue learning, like well beyond completing your medical degree, to continue learning specifically about psychology and model yourself after many psychiatrists that have done this, Dan Siegel, Daniel Amen, Anna Lemke, so many of the guests that we've had here on this podcast. We have models for psychiatrists who have continued to learn and who have made themselves a trustworthy practitioner who thinks critically about the nature of all these diagnoses and prescriptions. And then to the public, I would say it is ultimately your life. And it is, hopefully it feels empowering to take responsibility and to be as educated as you possibly can. And if you're someone who's listening to this podcast, you're probably well along that path of educating yourself about all of this. And just to realize that, the truth is, I would say psychiatrists are not like geniuses about your condition. They're not experts on your experience. The paradigm from which they work tends to be invalidating, disempowering, and ultimately harmful. And so be very careful about where you place your trust, and just like Nesseret is saying, like, be open-minded, be curious, seek out approaches that you might not hear about on the commercials that tell you to ask your doctor about this new medication, because the stakes are very high here. You know, this is our
Mm.
lives, this is our health, this is our well-being, this is the kind of clarity of the masses that we're talking about. It's a dystopian world that I can imagine, where the majority of the public, we're already at like 1 in 5. 1 in 5
Mhm.
people in the US
Mhm.
alone have been prescribed a psychiatric drug. It's a dystopia to imagine a future where the majority of people, their mind is clouded and dulled by psychoactive substances. That's not a world I want to live in, and it's not a world I want my kids to have to inhabit. So the stakes are very high, but
Mhm.
I'm so grateful, Nesseret, for people like you, for you in particular, not just people like you, but for you. I think you are a very important voice, and I hope that, you know, your following grows exponentially, because you just have a very grounded perspective and very, like, just legitimate professional experience to draw upon. So thank you so much for the impact that you're making.
Yeah, thank you. I appreciate you, uh, the work that you do as well, and I appreciate your kind words. Thank you.
You're welcome.
Mhm.
And I just want to say thank you to the Psychology Is audience for listening to this whole conversation. And hopefully you are starting your own conversations in your own social circles about all these issues, and that we do so with love and compassion, but also critical, rational thinking.